lecturer and pediatric oncologist at Stellenbosch University. Dr. van Zyl is a member of several national working groups of the South African Childhood Cancer Study Group. She's also involved in an international research project about the late effects of childhood cancer in low and middle income countries. She developed the first long-term program for childhood cancer survivors in South Africa and will be implementing it nationally as well. Dr. van Zyl has 17 peer-reviewed publications and a book chapter in the last 5 years and is involved in 9 ongoing research projects and has clinical trial experience. She has extensive experience in undergraduate and postgraduate training and is the current chair of the Department of Human Resources Committee. Dr. van Zyl has a keen interest in bleeding disorders and benign haematological disorders. She has been a member of the Medical and Scientific Advisory Committee of the South African Haemophilia Foundation since 2006 and served as a chairperson from 2020 to 2021. She has served on several advisory boards and is striving to improve haemophilia care in South Africa. So we're very excited to hear her talk today, which is titled, Is Cure the End of Childhood Cancer Journey? And I'm going to hand over to her to take over. Thank you. Sorry, Anel, I think you are muted.
Sorry, I was just looking for the screen to unmute myself because I'm sharing my screen already. Hi, everyone. Thank you very much for that kind introduction. Just checking that you can see my slide once again.
Yes, all good.
All right. Thank you to everyone who's attending this afternoon. I'm going to be sharing a lot of information that I learned during my PhD journey. I hope some will not be too much, but I'm going to share everything because it gives a background when we come to the psychological, the stress portion where you are obviously more interested in. All right, so the title is Cure, the End of the Childhood Cancer Journey. So the impressions of the general public about the childhood cancer journey, it's a very emotive topic. When you Google images of childhood cancer, you'll see the children with lost all their hair. Often they are very malnourished and not looking particularly happy. And there's a lot of sympathy and empathy around this journey. People think of the unfairness of children having cancer. Some people don't even know that children can develop cancer. And there's obviously a lot of suffering during the childhood cancer journey. For some children, they have very little, but for other children, it can be really a very, very difficult journey, and then for the family as well. So people normally think that the childhood cancer journey ends on the last day of the treatment when they, as it's the tradition, ring the bell in the childhood cancer ward to signify the end of their journey. And also maybe once complete remission is confirmed after treatment completion. But this is not the reality at all. The childhood cancer journey is actually lifelong for most children, and I'm going to share with you now why. So the good news is that our childhood cancer survivor population is definitely growing because of the improved survival rates. We started off in the 1960s with barely anyone surviving. And in high-income countries, the survival rate is 80% or higher. From the graph on the right, you can see the dots on the right-hand side. Those are all the high-income country survival rates for childhood brain tumors. But lower middle-income countries, we are not there yet with survival rates, but we are improving all the time. The not so good news is that although many children these days survive cancer, up to 75% of them will actually develop at least one late effect. So the term late effect defines any complication that develops after treatment. It can develop a few months after treatment, but some even develop only when the survivors then reach their 40s, for instance. The development is dependent on the type of cancer that they had or the treatment modalities that they received. It can be physical late effects that can include any organ, or it might be psychological of nature. And there's actually a very high cumulative incidence of severe and life-threatening chronic health conditions by the age of 50 years, as you can see there from the stats. So that is why long-term follow-up care is essential for childhood cancer survivors. Now, what is that? That means it's usually annual. Initially, we follow them up more closely, but in the end of the 5 years, it becomes annual, usually lifelong follow-up with a dedicated multidisciplinary team. Now, this is the dream. It doesn't always work like that in low middle income countries. And this team must include the disciplines of psychology and psychiatry. And this is something we have to strive towards. And in most of our units, we still have to establish that. During long-term follow-up, we will then do surveillance investigations to try and identify these late effects early, because the earlier you identify them, you can step in and intervene and hopefully then address it early and improve outcomes. And then we have to provide holistic support. And again, not just focus on the physical well-being, but also the mental health well-being. So previously, there was no published information about long-term follow-up care or any comprehensive late effects assessment in South Africa. And that's why we decided to do this research. And there wasn't any formal national long-term follow-up program in existence. So the aim of our research was to determine the number and extent of medical and psychological sequelae of cancer and its treatment in childhood cancer survivors, and to develop a long-term follow-up model relevant to our environment. So this is a brief overview of all the different components of the study. First of all, we did a scoping literature review to document the knowledge about long-term follow-up care practices and models with the focus on low-middle income countries like ourselves. We then did an electronic survey to actually investigate and document what the pediatric oncologists and hematologists in South Africa were actually currently doing and what their reported knowledge about long-term follow-up care was. And then came the prospective components, where we recruited 160 childhood cancer survivors from our Tygerberg Hospital cohort. They were all 5 years or more after treatment. And then they signed up for a late effects assessment in person. We evaluated all the medical information and then did surveillance tests depending on their cancer or the treatment they had or certain abnormalities we found to document all of these late effects, the physical ones. We also asked about any psychological complaints or diagnoses before. Then we determined their psychological distress amongst adult childhood cancer survivors. There were 40 of them of 18 years and older who took part in this portion of the study. And we used the Brief Symptom Inventory 18 or BSI 18. I'm sure all of you will know about that tool. And then we used health-related quality of life tools developed in America to assess specifically their health-related quality of life in survivors. It's a tool that was developed specifically for childhood cancer survivors. Then we looked at the group of survivors who were not able to come in for in-person long-term follow-up assessments. This was also halfway during the COVID pandemic, so not everybody could come to the hospital. We also couldn't locate many of our survivors, which taught us something about retaining contact with our survivors. So then we did an electronic linkage analysis of how the other survivors who didn't come for in-person assessments, how they engaged with our healthcare system and tried to find information about late effects that they were seen for at other healthcare institutions. And then we made a proposal for a formal long-term follow-up program for South Africa. So just briefly, in the scoping review that we did, there are some very well-developed long-term follow-up programs in most high-income countries, but as we expected, found a lack of publications from low-middle-income countries, only 15, and very few countries actually offer proper care due to many barriers that we are very well aware of. The most used long-term follow-up models anywhere in the world was cancer center-based, where survivors would only visit the pediatric oncology unit for follow-up. And then in low-middle income countries, they used community-based follow-up where they didn't go to the pediatric oncology unit anymore because it was too far away and the follow-up was only in the community. But everywhere around the world, the shared care model was increasingly being used. So that's where the pediatric oncology unit will follow up survivors, but mainly they were seen by GPs or by nurses. And then a risk stratified approach was very useful. So that's where survivors are assigned a risk like low, medium, or high risk to develop late defects, and depending on that risk stratification, will be seen less or more often. And then there are certain long-term follow-up guidelines that's used in the pediatric oncology world. The ones from the United States called the Children Oncology Group guidelines, they were most often used. But in many of the countries, especially the ones with less resources, the guidelines needed to be adjusted because they simply couldn't do all of the high-level investigations as often as it was actually required in the guidelines. So they adjusted them or they created their own. The barriers that we are faced with in following up childhood cancer survivors are many, obviously including funds, a lack of trained staff, a lack of knowledge amongst healthcare professionals and survivors. They don't realize the importance of following up for such long periods. A lack of time, we all know that barrier. Inadequate transport, especially the more rural the survivors stay, the less they are able to travel a big distance to a pediatric oncology unit. And then transition of care from pediatrics or adolescents into the adult follow-up system. So the next study we did was to survey our local practices. At that point in time, in 2019, there were 31 pediatric oncologists in South Africa, and almost 2/3 of them responded. Almost everyone regarded long-term follow-up care as important or very important, which we were very happy to hear. And most, 91%, were providing long-term follow-up care at that time. But only half regarded their knowledge about long-term follow-up care as good. Only 2/3 had received formal training in long-term follow-up care during their fellowship. And only half discussed late effects at the cancer diagnosis. So this means that we are not informing our survivors about what to expect when they're done with treatment. So they're not aware what to look out for and to seek help. So we concluded that obviously clear guidelines adapted for our local context associated with a national program should assist in providing adequate care for our survivors, and that we must provide formal training for our pediatric oncology fellows about long-term follow-up care. The next part was the documentation of all of these late effects in our Tygerberg Hospital Childhood Cancer Survivor cohort. So we performed a prospective analytical cross-sectional study during 2020 to 2021. We invited all the contactable survivors that we had on our local childhood cancer registry. And then when they came, the study procedures included the long-term follow-up assessment with a complete medical history, asking really about all health complaints that they've had, medications, diagnoses that were made since completion of treatment, and also a complete physical examination. We documented all clinical abnormalities mentioned in the medical history and also found in the physical examination. Then we did specific directed surveillance investigations using the American guidelines that I referred to earlier, the Children's Oncology Group. So these would be special investigations such as blood investigations, X-rays, scans, bone density evaluation, hearing tests, etc. Of all the clinical abnormalities that we then documented or found through the investigations, we identified the ones who were clearly cancer-related, and we graded them using the CTCIE classification that's very commonly used in clinical trial environments. Grade 1 and 2 would be more mild side effects, while 3 and 4 would be more severe. We then also classified these late effects that we found as being either significant or insignificant to the survivor. For instance, we could potentially find an abnormal, mildly abnormal blood level of some sort, like magnesium or like platelets, but the survivor wasn't even aware of this before, hasn't needed to seek any treatment or intervention for that. So something like that we would then deem as insignificant. Whereas permanent alopecia, hair loss, for instance, that the survivor wouldn't be able to cover easily, would be very significant to them, or a leg length discrepancy, for instance. So we had 665 survivors on our database, and in the end, as I mentioned, 160 were evaluated. We, in addition to all the medical details and the complications that we documented, we also asked about educational attainment. Most of the survivors were still at school, and we asked them to provide a school report as well. And then we used the hospital classification to document their socioeconomic status. It was limited in the sense that we only used the income of the family to document that. There are obviously other more detailed ways that one can do this. We obviously documented the clinical abnormalities and the late effects and the significance, as I mentioned. So for those of you who are not very familiar with childhood cancer, it's usually diagnosed at a young age. If you look at the table on the left, the age of diagnosis, the mean age of our patients was 4.6 years. And the mean age at the time of the study visit was just under 15 years of age. But we saw survivors from 10 to 51 years of age. And the period since cancer diagnosis was a mean of 10 years. Just more than half of our patients had hematological malignancies, meaning leukemia and lymphoma, and the rest then had solid malignancies like kidney, liver, or bone tumors. Luckily, most also had limited or early cancer disease at diagnosis. Of note, the majority of them, 65% of the survivors, who had previously discontinued long-term follow-up, needed healthcare intervention for some of the late effects that we identified at the study visit, and they were not even aware of them, or they were aware but hadn't sought medical help. So on the right-hand side was just a detailed breakdown of all the abnormalities we documented, which was 1,044, 6.5 abnormalities per survivor. Of those, 62.2% were cancer-related. So that means most of the survivors, 91.3%, had at least one late effect. And that's a higher percentage than was documented in the international literature for fairly similar studies. The good news, though, is that the majority of these late effects were mild, of grade 1 severity. But even though they were mild, half were considered clinically significant. So what systems were involved most commonly was the gastrointestinal system, metabolic abnormalities, hematological, musculoskeletal, and neurological late effects. Specifically, psychological or psychiatric disorders, only 15 of the survivors, which came to 9%, have been diagnosed before with these disorders, and they were anxiety, agitation, depression, suicidal thoughts by 2 survivors, a suicide attempt, luckily unsuccessful, and then ADHD. Before, the ADHD was diagnosed after the diagnosis. Also, the nutritional status of our patients worsened, more became obese, and then just more than a third had decreased growth velocity. The majority attended mainstream schools, but half had below average school performance. And their socioeconomic status as measured by the family income worsened. So 17% were fully subsidized, having very little or no income at diagnosis, but that rose to 52% being fully subsidized at the study visit. So we identified a few risk factors that were significant for the development of late effects. And obviously that was cancer diagnosis. Having a brain tumor, for instance, would lead to more significant late effects. The intensity of the chemotherapy, whether you received radiotherapy, that in all the studies across the world will lead to more severe late effects. And then also the late effect severity, as I've just said, we proved that that was significantly associated with having received radiotherapy. And then those with a solid tumor were also more likely to develop more severe late effects than those with leukemia and lymphoma. So this was the first comprehensive documentation of late effects of childhood cancer survivor cohort in South Africa. And as I've said in summary, most developed mild or moderate late effects. The percentage, 91.3% of them, was higher than was documented in the literature. We identified the diagnosis, chemotherapy intensity, and radiotherapy as the significant factors. And most late effects did have a health impact on the survivors, being clinically significant to them. So even more crucial to develop long-term follow-up surveillance plans for our survivors so that we can detect these late effects. For some, they may be subclinical to the survivors, but we can still address them before they become clinically significant and already then have caused damage. So the next part of the research was identifying and assessing the psychological distress of adolescent and young adult survivors in our cohort. This was quite a small study, It was prospective, again, analytical cross-sectional. We invited the survivors of 18 years and older to take part in this portion of the research. 40 survivors took part, and as mentioned, completed the BSI 18 in person, or once COVID struck, they completed it online, just a few of them. So as you are aware, the BSI 18 contains 18 items, and the domains are somatization, anxiety, and depression. And participants are self-reporting symptoms in the last 7 days. So we calculated the Global Severity Index, or the GSI-T score. Unfortunately, there's no normative data available for childhood cancer survivors. And we used 3 different case rules to try and identify the survivors with distress. So these 3 case rules have all been reported in the literature. The standard one is where you use a score of 63. If above 63, then you identify the survivor as having psychological distress. But other papers have suggested a score of 57, and most recently of 50, that would be more reliable in identifying somebody with psychological distress. We collected the normal data and also about employment and marital data. There was acceptable internal consistency, and the ones that were identified as having distress were then referred for formal psychological evaluation, but this wasn't, that part wasn't included in the reporting for this study. I'll say something about that a little bit later. Okay, so this cohort, the age at the study visit, they were older, obviously, because they were adults. So the mean age was 24 years, and the period since diagnosis, almost 17 years. And they had a range of different childhood cancers. So the majority of them did an in-person assessment, and only 7 online due to COVID, as I said. And half of them had 5 or less late effects, but the other, just below half, actually had 6 or more late effects. 60% again had mild to moderate late effects, but 40% of them did have severe sequelae. And half had a low socioeconomic status. Almost all of them were single, 90%. Half had completed secondary education, and only 10%, 4 of the participants, had completed tertiary education. And then only 40% were employed. So these values were also lower than, for instance, reported in Turkey. So this is just the graphical results showing the proportion of the childhood cancer survivors with psychological distress, comparing the 3 different case rules. So the green bar shows using the GSI-T score of 63, only identified 10% of the participants with distress, while, as expected, a higher cut-off T-score of 57 identified about 33%. And then using the more recently recommended GSI-T score of 50, identified almost half of the participants as having psychological distress. When we looked at the significant factors associated with having psychological distress, again, radiotherapy came up, the presence of having a late effect, a follow-up period that's longer, 11 to 20 years, and then having more or severe late effects. On multivariate analysis, the follow-up period having a higher number of late effects and the severity remained as being significant. So this was a pilot study, as I said, a very small study but it reported novel data on psychological distress amongst our survivors locally. And the prevalence was also higher than reported in the literature using two different case rules of 50 and 57. I've mentioned already the significant contributing factors, and this study actually provided novel data. The other studies didn't take severity of late effects into account. So our conclusions were mainly that survivors must have regular screening for psychological distress during follow-up, preferably by using a validated tool such as the BSI-18. There are many others. And those identified as having distress must then be referred for formal evaluation. So there's definitely research opportunities here for us going forward. This was the very first study that was published about this topic in South Africa, and there's a lot more to do. So we want to do a follow-up larger local study, obviously including more participants, but with concurrent formal psychological assessment to really be able to evaluate the tool and properly evaluate psychological distress and issues. And then the BSI-18 tool needs to be validated in this specific population. The next part was evaluating the health-related quality of life of adolescent and young adult survivors. As you all know, health-related quality of life is the impact of an individual's health status on their perceived physical, mental, emotional, and social functioning, and their ultimate life satisfaction. So in childhood cancer survivors, there's contradictory reports. Some reports saying there's poorer health-related quality of life for survivors versus controls, and others reporting a better health-related quality of life because of the traumatic experience that they went through. They actually have psychological positive growth, is the hypothesis. The current long-term follow-up guidelines do not include health-related quality of life assessment, but a lot of papers are recommending that we should routinely measure this. And at that point, we had no data about this for survivors in South Africa. So 94 of our bigger cohort of 160 survivors completed the Minneapolis-Manchester Quality of Life tool. As mentioned, there are many, many tools, as you are aware, to assess health-related quality of life, but not specifically for childhood cancer survivors. So this tool was specifically then developed for this population. The participants aged 13 to 20 years completed the adolescent form, and those 21 to 55 years completed the adult form. There's also one for the young ones, 8 to 12 years. The domains included physical, cognitive, psychological, and social functioning, body image, outlook on life, and then the overall health-related quality of life. The overall Cronbach alpha was good to excellent, and the construct validity indexes were also good. We calculated then the scores for the different domains and the overall health-related quality of life score. So this group, the age at their study visit was around 20 years, with 13 years post-cancer diagnosis, and they had about 5 late effects identified on average per survivor. What we noted is risk factors for poorer health-related quality of life is the age at the study visit, again, the number of late effects and the severity. And then female sex was definitely a risk factor for poorer psychological functioning. And one of the lower strata of socioeconomic status was significantly associated with poorer body image and outlook on life, but socioeconomic status as a whole wasn't a significant risk factor. The adult cohort had a poorer psychological and social functioning and also a poorer body image than the adolescent cohort. And comparing to the original, the USA cohort, the adolescents had a slightly lower mean overall health-related quality of life score. We actually expected it to be significantly lower, so that's a good finding. And the adult cohort did have lower scores for all domains, except the body image and outlook on life compared to the original USA cohort. So the subsets of survivors at risk for poorer health-related quality of life were then females, older age, and those with a higher number and severity of late effects. So we concluded that one should also incorporate high health-related quality of life status in risk stratification for these patients, so that one can actually do holistic long-term follow-up planning and care for these patients. So there's also another future research opportunity because these questionnaires have also not been validated in our South African survivor population, and this is definitely much needed. The last thing we did was to assess the patients who could not come in for in-person visits. The only thing that we could do was doing a linkage record study where you link data in 2 or more databases via a single patient identifier. The number of hospitalizations could be a proxy for chronic diseases burden in childhood cancer survivors. And once again, we didn't have any information. So we did a deterministic record linkage study, also a short period early in 2021, late 2020. And we looked at long-term survivors registered in our registry. We used the patient hospital numbers and we linked data in the hospital electronic record system called Colloquium and in the laboratory results platform with the data that we had in our cancer registry. So we documented all their outpatient visits in any of the healthcare institutions in the Western Cape, because all of them use the Colloquium system, all hospitalizations. If we could find any diagnoses, we were really hoping that people would document the ICD-10 codes, and we could also see dates of death. And we also tried to access medical data once we had identified a patient who we wanted to know more. So I visited quite a few hospitals and obtained access to the folders from the Western Cape Provincial Health Research Committee. We did realize that ICD-10 code capturing was quite inadequate, and that's why I had to go and dig in a lot of patient files. We excluded a few patients who had died that we were not even aware of. Some died due to late effects, and some with incorrect or minimal data. In the end, we included 346 survivors. And these 346 survivors had just more than 4,000 healthcare institution visits since they completed 5 years after diagnosis. The majority of them, 88%, were ambulatory clinic visits with a mean number of 10.5 per survivor. They had 477 hospital admissions, 1.4 per survivor. And this was the thing we were quite interested in this table, showing that the majority still attended tertiary healthcare institutions, 62% being of the visits occurring there, followed by primary care institutions, and lastly, only a small proportion at the secondary level institutions. So this information could help us planning healthcare engagement of survivors in the future. The number of visits and the rate per person years were highest for the very young survivors, 0 to 4 years at diagnosis, females, survivors of leukemia, those who only had chemotherapy, and then a follow-up period of 16 to 25 years. The areas that they visited mostly was the pediatric oncology unit, followed by the general adult outpatient clinic, emergency rooms, endocrinology clinics, obs and gynae, neurosurgery, etc. And I've just highlighted the psychiatric clinic visits. There were only 91 visits that we could pick up, forming only about 2% of the visits. But I think that survivors' mental health problems are really underdiagnosed, and people don't always link it to the previous childhood cancer diagnosis. Again, the risk factors for increased healthcare visits were very similar to those for admissions. Was females, the ones that were diagnosed at a very, very young age, and then age at last contact, 36 years or higher, and patients who had a brain tumor. We did note that the visits decreased as the follow-up period increased, which worried us, which means that the older survivors are not getting adequate health care that they need. This is a lot of information, but we can just briefly mention, just to signify how difficult some of our survivors' lives are, just as difficult as other patients who didn't have cancer. Some of our survivors contracted bloodborne, potentially, or not potentially, sexually transmitted infections. We cannot be sure whether they contracted that during the treatment by blood products or not. For instance, 18 of our survivors had a total of 38 cases of assault, pointing to the very violent communities some live in. 10% of females had significant pregnancy issues. 11 had developed subsequent malignancies, which is another threat to them. Psychiatric disorders that we could find that were documented was depression, behavioral disorders, overdose, and then PTSD. So we definitely saw increased healthcare use for females, the young ones, the older patients, and brain tumor diagnosis. But as I said, we do not see that our older survivors seem to be engaging enough in healthcare, because we know that they have increased chronic health conditions and they should be engaging more. We also informally noted that survivors frequently did not disclose their prior cancer diagnosis, in the clinical notes. So the doctors had no idea that they had childhood cancer, which could help in actually identifying the problem and knowing how to deal with it. So we proposed a long-term follow-up program for South Africa. We thought that having a risk-based program where we assign low, medium, or high risk to survivors would help. Also for the program to be shared care, because it's not sustainable for survivors to be followed up at only tertiary care centers. It needs to be a national long-term follow-up program that must be sustainable and to ensure equitable care for all the survivors across South Africa. One definitely needs a survivorship care plan. So that's a document where everything about the cancer diagnosis and treatment is documented, and it's explained what the risks are for that specific person, what tests should be done when. So really very valuable information for someone who engages with a childhood cancer survivor for the first time. So if you are ever involved with a childhood cancer survivor, you should ask whether they have a document like this, but it's a fairly new entity for us in South Africa, and something that we have to include in our long-term follow-up program. We also definitely have to assure adequate transitioning of care from the pediatric to the adult healthcare providers, so that the knowledge doesn't get lost and goes with the patient to whatever healthcare professional that they see. And then importantly, we need to add screening for health-related quality of life and psychological distress for all our survivors, and not just at one occasion after treatment, but actually yearly, as some publications have shown longitudinally that it does get worse as time goes on. We have to make sure that healthcare professionals, and specifically our pediatric oncology fellows, are properly trained in providing long-term follow-up care. Another very important thing is to retain childhood cancer survivors in a long-term follow-up plan is very challenging anywhere in the world. Some survivors, when they finish treatment, they really don't want to come back to the place where they needed to receive treatment. They don't necessarily want to be reminded of their childhood cancer journey. So we have to explain from the get-go why it's important, and that is an essential part of their treatment as such. So they have to understand why they need to come back and the benefits of long-term follow-up care. We also have to try and follow them up as close to their homes as possible. As said before, they can't travel huge distances just to go to a tertiary care institution. I'm not going to go through all of this, but this is how we divided patients into risk groups of low, moderate, and high chance of developing late effects or having late effects already, and how and by whom they should be followed up. And as I mentioned, the idea is to have a multidisciplinary team, definitely including psychologists at least. So the final remarks is that the WHO has a goal of achieving a cure for 60% of children with cancer everywhere in the world by 2030. So with this goal in mind, there's going to be a lot of survivors, and we have an ethical responsibility to prepare for adequate long-term follow-up care for all our survivors in South Africa. And I cannot stress enough that multidisciplinary care is essential. We are planning to incorporate the National Long-Term Follow-Up Program into the National Health Insurance Plan to ensure appropriate, standardized, equitable care for all our survivors, which will assist with the WHO's vision of achieving universal care for all close to their homes. And the ultimate aim, obviously, is to contribute to improved outcomes and quality of life. So this is just a list of a lot of people to thank who were involved in collecting and interpreting the data. So I have given you quite a mouthful of information, and I'm very happy to now answer any questions you might have. We really want to invite people who are interested to engage with us about research, because I have highlighted a few projects that we really think is necessary, and we want to take that forward.
Thank you so much, Anel, for that succinct overview of what's clearly a very substantial body of research. It was very interesting to hear. Before I open up to my colleagues, I just wanted to check, when you were discussing the psychological distress factors, you mentioned that there was one part that wasn't covered in this study, and I don't know if you want to perhaps talk about it a bit further.
Yeah, I don't have the data. So that was the survivors who did have psychological distress that was identified through the tool. We had to refer them for formal evaluation, but I haven't been able to gather that data. So this, as I said, was a pilot study. So the best design for a study like this, to be able to truly assess the performance of the tool and the levels of psychological distress, remembering that this was done in the period during post-COVID, which could have also added, to a lot of things. There's a lot of limitations again. So having a much larger cohort with concurrent evaluation at the time would really be the best kind of study to do. So we need your department's expertise and input if we want to do a study like that.
Awesome, thank you. Colleagues, if any of you would like to pose some questions to Anel, please put your hand up. And if you'd like to put them in the chat, then I will also be having a look at that. Leslie?
Thank you. It's Leslie Swartz here. If I were only a little bit younger, I would be first in line to rush to work with you, but I'm not. I mean, thank you very much for a wonderful and comprehensive presentation, and I hope that your plea for people to work with you will find a place in our department. Just one sort of comment on I've got a number of comments and questions, but one comment on the sort of levels of distress. I mean, if one looks generally at the psychiatric epidemiology of South Africa, a lot of people suggest that in the general population there are higher levels of distress than in other countries.
Mm-hmm.
So, I mean, this, you know, when I see you want to do a follow-up, I think, oh, this would be just so perfect for a case control study with neighborhood controls. I'm sure you've thought of that.
Yes. Yeah, definitely. I wanted to include controls in my study, but I was gently but firmly advised by the PhD committee that wouldn't have been doable in the time frame that I had.
Yeah, no, they're right.
Thanks for bringing that up. But that was definitely another part of that study, is having controls. Definitely.
And I mean, another question that I'm just sort of curious to ask you and members of your team about late effects. But I mean, maybe don't answer. Just sort of I wonder about the late effects of all of this on you and what it's like to do this work, to follow these people up, to see such levels of distress. I mean, it's quite a thing. Eh? And just thank you for doing it.
Yeah, no, I mean, we can talk an hour about that. But I think my opinion is generally people who go out and qualify themselves as pediatric oncologists, you do have some coping skills and ways to approach this work, and you can't be overwhelmed by it. The feelings will wax and wane. But we do have our own kind of coping skills, but support in our team is definitely important. But, you know, it's so gratifying that when I saw some survivors, adult survivors who had long since stopped follow-up, they were not informed about late effects previously. They had no idea. So they were sitting there and just so thankful to be able to understand. But why couldn't I finish school? It wasn't because of me being adequate. It was the radiotherapy I had for my brain cancer. And now I understand a lot of things about myself. So that was actually very gratifying to be able to give that to them. Thank you for your comments. I see there's a question in the chat, but there's a person with a hand up.
Shall we first take the hand up? So that's by Rizwana. Rizwana, if you can unmute yourself.
Hi, Dr. Van Zyl. Thank you. That was such an interesting presentation. And you're right, there's so many sort of avenues for collaboration. So I'm really interested in reproductive health, and I've done a lot of reading about adolescents and young adults with cancer and future fertility and that sort of thing. Is this also an issue for patients with childhood cancer? Does it at all affect their future fertility? Okay.
Yeah, definitely. It depends on a lot of factors. It depends on the age of diagnosis, the types of chemotherapy agents we use, the cumulative doses. Also, if they had radiotherapy to, you know, the ovaries or etc., or the kind of surgery they had. So there's a lot of factors. There's a lot of literature on how to assess fertility risk. So that's something we need to inform the patients about and the parents. But often after treatment, well, the child may be 3 years old when they get treated. We give the information to the parent, but the information doesn't transfer when they get older. So that's why long-term follow-up is also so important. And some may think that they will always be infertile, meantime back at the ranch. They are not.
Yeah.
and they actually need to use birth control. So there's a lot of issues around sexual health and fertility also for childhood cancer survivors, yes. And something that has not been explored in South Africa.
Okay, all right. Well, I'll send you an email then.
I'm looking forward to it.
Okay, thank you, Rizwana. And I see now that Tyler has posted a question in the chats, but I see you've put your hand up. Would you like to chat to Anel directly?
Yes. Hi, Dr. Gonzal. It was
Hello.
actually for Dr. Rimini's question because I'm doing my honors project on this, and reproductive issues was a significant problem in the literature, particularly for women, but also for men. And like you said, there's no research on this in South Africa, but I think if there was, it would obviously pop up.
Yeah, so your question in the chat was, when is the national program likely to be rolled out nationally? Probably earliest next year. I have compiled my recommendations based on our findings and what's known in the literature. I do need to, have discussions with my colleagues. Luckily, we are a very small group in South Africa, just to tease out any queries that people might have, so we can panel beat it into the final version and then to employ it.
Okay, thank you.
Okay, I think that's it. Unless anybody else has any question, I think I'm going to end it there. Thank you so much, Dr. Van Zyl, for the very informative talk and for also engaging with our audience. I can see there's a lot of people interested in collaborating with you, so I'm sure they will take that further and email you. I'm going to just end the recording there.
Okay, thank you so much. I really appreciate the invitation, and I've enjoyed engaging with you, and I hope I receive a lot of emails.
Okay, thank you, everyone.